Today we have very important topic to talk, and thanks to Krishna and the West Bengal Society that we could share our knowledge and our experiences with you all. Everybody is getting expert day by day with all this new modality, which is ultrasound in pain management. And I personally think, lately speaking, because we also learned it about 5-10 years back, only not too long back, and we found it such a useful tool, and we were really missing it, and we really need it in our own times, when we started our pain practice. So to my message to young people is take it up early, start it early, get more experience and practiced about it. It's a very very good tool. No pain specialist will escape the ultrasound in pain management over a period of time if you really want to be a good pain specialist, good and safe, especially. So that's the importance of it. And yes, with the given lifestyle, what all is going on around, you see all this mobile menace, with the WhatsApp and nothing coming up, and people having a very bad lifestyle. They are not really taking care of the postures and all, and that's what is bringing more and more the neck pain and the upper back pain. And many a time it could be just a myofascial pain syndrome, but yes, there would be situations if you don't take care of the neck postures and all, people will have cervical disc disease, and you'll see in the coming generation you'll have more and more of these problems coming up. That's the whole point. Let me see why its next slide is not showing. Okay, so that's what I said. Soft tissues, we can do soft tissue procedure, and you can do it better and justified in an ultrasound guidance. You can really see the taut bands, when you see ultrasound guidance, your muscle taut bands, and you can really go and hit your needle there and do the things. Although we've been doing a trigger point injections, why I'm saying so is there's so many trigger points in the posterior neck muscles, especially upper back muscles, trapezius and other back muscles, which can be reason for pain, especially in the scenario when the people are doing a lot of desktop job, laptop jobs and mobile work. So this is the important thing. This is just passing reference because we really don't take care of those situations, but they are very very important again. People who have ultrasound machine in their OPD settings and in their theater rooms, I think probably they will really pull it up and just have a diagnostic tool. This is equally a diagnostic tool. Today I'm going to touch upon the stellate ganglion block, because we all know how important it is in the pain scenarios. I'm going to talk about the cervical root pain and how do we do cervical root blocks, and then we're going to talk about the third occipital and occipital nerves and greater occipital GON, and I might touch upon AO also to some extent. And then definitely a very important talk is the cervical facet syndrome, and we're going to talk about cervical facet joint injection, cervical facet nerve injection, cervical facet RF, and how best we can do it ultrasound ways. And then we have we all know Cervico-Trigeminal complex with circuitry is there, and you really have to take care of the trigeminal nerves also sometime, because we're going to talk about head also, and how we can best do it peripherally, and it's really catching up very fast. One important thing is the neck is really laden with a lot of vessels around, be it the arteries, be it the veins and all. We are more worried about the arteries for that matter, but you can't expect your needle to go into veins and keep injecting your particle in between the veins also. So it's so important thing. And then esophagus and trachea, everything comes in the way. So really have to see, because with the x-ray you see only bones, you don't see any soft structure. That's a very very big problem, and that's what few slides I'm going to show. We have a radiation free. Why I say radiation free? We at our age now, after 10-15 years of practice, we realize how much radiation we have been absorbing. In my own practice, I've done about 2 lakh of the shots, CM shots. Can you imagine how much is the absorbed radiation which I have in my body? And over a period of time, it is very risky for malignancy and for hematological malignancies, leukemias and other things, and thyroid cancers and other things. And young people, it can be problematic for the infertility also. So once we have this ultrasound in our theater, I would do all work in periphery, especially the limbs, upper and lower limbs, and to some extent what Rajendra is going to talk, the hip and the gluteus and the pelvic region, and especially neck also is coming up very well in the way. We are left only with the thoracic and lumbar spine, where we don't have a very big say for the ultrasound, but otherwise many procedures can be ultrasound way. We can do even the parietal blocks also in ultrasound way. So ultrasound is very very big, very helping tool, and you can really do a radiation free work. And you might have to do 1 or 2 check shots, that's all. You don't have to do 30-40 shots for a procedure. Then we have this short procedure time for sure matter. If there is a vascular injection in the fluoroscopy, then obviously it takes longer. I've seen sometimes we try to do cervical injection, you keep seeing vessel again and again, and you keep changing your places, so it's very time wasting. Ultrasound, it really tells you straightforward. Then incidence of vascular injections is very very high, so that is another thing. Safety is there. With the ultrasound you have almost 0% chance of having a vessel injection if you're careful on it. Then you have this dynamic real time imaging. It is very very helpful for shoulder and other places where you have a dynamic imaging, and you really see when the pain comes. Patient tells you, okay, at this very moment, this very time my pain comes. This is such a help. It is in the cervical area also to some extent. What Narose is beautifully said once, and it's really rightly said, the only ultrasound can truly prevent the complication with direct visualization, whereas fluoroscopy can detect only the complications when it has happened, when the accident has happened. So it's not telling you beforehand, it is telling you accident has happened. So we have to prevent the accidents instead of treating the complications. Now, the first and easy and straightforward thing is stellate ganglion block. I think people will get used to these ultrasound modalities, and very very helpful tool for all people who want to begin with the practice. Ultrasound practice is one of the easy thing you can start doing it, and right thing, straightforward thing. This is you keep seeing a lot of vessels around, and if I know how we were doing all this stellate ganglion block all these ages, put a needle straight there, push the trachea other side and carotid one side and get in there onto the bone and come out 2, 3, 4 millimeter and give your stellate ganglion block. How can? People used to do 15 stellate ganglion block every alternate day, so for about a month or so. And I must be, there lot many times the drug must be lying in the one of the muscles. God forbid if it goes into one of these vessels here, what can happen? So we have to very very wary of these things now. More and more we have realized using ultrasound, we realize how risky it is doing a blind work in here. So I would advocate everyone to pick up an ultrasound thing and just at least have a look at it, what you're doing. So that will give you more of courage doing more ultrasound guided work. Yes, one has to be really seeing that you have to inject only this area. You're not going to inject there. There's a phrenic nerve lying there. You're not going to inject close to this. There's a recurrent nerve lying there. So you have to be careful on those accounts. Now this is the we can go perpendicular straight forward, but it's much advisable and much wiser if we go from the sidewise and we go the lateral view, we go lateral approach into lateral approach, which is much wiser approach and much right approach. Now it's said this is longus colli muscle. Your LA has to be subfacial. Remember, this is the perivertebral fascia. It has to be subfacial, and that is where the your ganglion lies, sympathetic ganglion lies. And how accurate you have to be. So it's very very important. And they did studies, they found when they put in a dye with the methylene blue and did a test injection on the cadaver studies, and they found that when they do it, it's in the subfacial way, you're just on the ganglion only. That's the rightmost place. And if you are over the fascia, you are nowhere touching the ganglion. So it's important to be subfacial. Now the target, how do we do it? Ultrasound should be in front of your eyes. This all should be in one line. Your eyes, your hand, your probe, and your screen. They all have to be in one line. Very, very important. Everybody has to study. If it lies one of this direction or the machine this side or patient other side, it is very disastrous. So one has to learn this technique rightly. Now this is where we just try to put in line. We try to go in line under the carotid. I'll show you the images now. And we just go in line. This is where the carotid artery is here. And this is where the stellate ganglion lies over the longus colli muscle. And we are coming from the sidewise and just putting a drug in there. You can manage with the lower volume. Remember, very very important. Ultrasound gives you such an accuracy. Even 1/2 or 1/3 or 1/4 volume, you can manage the same block efficacy what we do blindly. And this is what the trajectory is all about. We are just seeing the things, how the trajectory is there. But always the idea of doing this picture is always put the Doppler on. You have many vessels around. You have vertebral artery, you have a vertebral vein, you have the interjugular, and you have to bypass all of them. Initially, we have to hybridize. It's like going from petrol car to electric car, and then we have a hybrid car. And so we have to kind of hybridize. We should have a fluoro unit. Always check with the fluoro initially. But with experience, you can manage without fluoro also. And have a look. Your dye has to go in front of the first rib where the actually stellate ganglion lies, ahead of the first rib. And that is what it is all about. This is a beautiful study which was done. They found if you just put 5 ml drug, your drug walks vertical in the next to the stellate ganglion sympathetic chain. But if you start putting 10 ml like people used to do it for 7, 8, 10 ml, it starts going horizontal. So once it's going horizontal in this area, it is going more in the collateral areas where it is more collateral damage, and it's going unwanted LA spread, we call it. So that is not advisable. So ultrasound is very very helpful that way. Let's talk about cervical root map pains. We know it. We all know about the root map pains, where from it the pain is there, and there will be few cases where you initially have to do a either preoperatively or post-surgically or a failed surgery syndrome. You might have to do a root block, and it's a very helpful tool in such patients. It is very helping, I tell you, cervical root blocks. Yes, lately there is a very big risk of doing it the fluoro-guided, because a lot of vascular injections have been there, so it's almost banned or stopped world over. But yes, with the ultrasound coming in, it is really resurging again to some extent. But understanding the is important. Now this is what we are going to talk about. This is we start with the V6. So what is the anterior tubercle is very bright and prominent is there at the V6 and the C6. This is Schegne's tubercle. We all know it. We have been doing a stellate ganglion block over this. It's not advisable. It's a middle cervical ganglion, not the stellate, by the way. So we try to give it a C7. The C7, we have only the posterior tubercle. The anterior tubercle is very rudimentary, but then you start seeing the vertebral artery also by the side of it. But you can really see beautifully the C7 root there. And if you go even further little laterally over the first rib, you can see the C8 root also, and that is where sometimes you might have to go a C8 block. But about the if you start going a little upwards, then at the C5, both the tubercles, anterior and posterior tubercles, they are on almost same height, and it's like a catch sign. I call it as a ball catch sign. So it happens in there. And C4, C3, they're almost same. They start getting smaller, by the way. But it's called a double hump camel sign, typically speaking. And your nerve really jumps out of this, and that is what you're going to see in next few images. Now this is what it is. Anterior tubercle is really bright, and you really see it's shining, and you really see this is C6, and you see the root in there. This is a very good ultrasound image with a good machine, but yes, with practice you can manage to see this in all machines which you have with you. And this is the C7, which I just mentioned you a minute back. And this is the C5, the two anterior and posterior tubercles. If you very carefully watch, you see the festal pillar right there, roundish pillar. I'm going to talk more about this after some time. And this is what Nerozzi studied. When he started putting a Doppler, always you have this thing, put a Doppler or a power Doppler on, and you see the vessels in there, and you start seeing vessels. They found the vessels sometimes lying even in the foramina areas, and you have to be careful. You cannot be just blind, go in there and do your shot there. It can be disastrous sometime. And I'll give you the study after a minute. So this is how you're going to do it. The patient's head has to be turned slightly away. You can have a semi-decubitus position on the part of the patient, or you put something under the some pack under the shoulder also, and you go from side in line with the probe. And this here you see the posterior tubercle, you see the anterior tubercle, you see the nerve. You don't inject when the nerve is right there in the dip of the trough. You just see when the nerve jumps out of it here, and that's where you tend to give your injection. As soon as it jumps out of the tubercle, posterior tubercle, you take a needle up there and put there. Although it is little extra foraminal, but it is as good as the transforaminal injection in many ways. So it's good enough, and you're away from the vessels most of the time. But yes, you have to be careful. Put a Doppler on and see the things, and then you start putting. As soon as you put your drug, you should start seeing each drop of your drug spreading around, and then you really start seeing that is inflating, and you see the flow of the fluid. It should not happen that you put something and you're not seeing it. It should not happen anywhere in the ultrasound guidance. And never ever miss the tip of the needle. Never ever miss the tip of the needle, because your tip of the needle may be lying somewhere here if you are not looking at the shaft of the needle. So always have a focus on the tip of the needle through and through. And this is what the position is. You do it in lateral position, or I will tell you semi-decubitus position, and you have to come from posterior to anterior, and you just give posterior to the root there. You never come anterior to the root because there are many reasons. I'll just explain. And this is what I'm trying to say. Posterior tubercle, go and touch posterior tubercle. Fluoroscopic validation for your satisfaction. Over a period of time, you will stop doing it, but yes, there is no problem initially. In some few cases, you do combo thing, or in difficult cases, you combo it. And this is what it is. Your needle is coming from the side. You put in a dye. You see your dye is walking in and out. Even extraforaminal is good, I told you. It works sometimes as good as transforaminal injection in these situations. Now, what is recommendation? This says this is beautiful lines I must read for you. 20% of the dissecting cervical foramina contains either deep or ascending cervical artery within 2 mm of the directed needle target for the procedure. These arteries were found to enter in the posterior foramina in 33% of times. Remember, please, You don't see beyond bones for the matter. It's all blind thereafter, and you don't see the medullary arteries. That's another very big worry. It's a smaller artery, so you have to be careful. Extraforaminal injection work as good as transforaminal spreads. The pulse is keep your a very important point here. Transparent transducer perpendicular as you can scan, and to keep your desired vertebral level inside. If you angle your transducer, you may see a level above or below. Remember, if you just slightly angle it, you may see a level. So I always keep telling my assistant and other people or second person in the OT, if I'm just losing the sight, please keep a watch that I'm not losing the vertebra. Always inject from the posterior to anterior direction to avoid the internal jugular veins, vagus nerve, common carotid artery, and 80% of the time the anteriorly located radicular artery in the cervical foramina. And Doppler may be helpful to find the feeder vessels I told you, and if possible use a blunt needle if possible. This is a one study just for the sake of interest. People are starting intradiscal injection PRP in regenerative medicine with ultrasound guidance. Okay, we've been doing fluoro, it's okay, you can do this. Now this is to do with the facet joint pain, and this is, we know it, this is the J line with the epidural target is there. This is the facet joint pain, and these are the joint pain maps. People will come, many of these patients will have a joint pain map. There are few approaches. I'm going to talk about the posterior joint approach, intra-articular. Then I'm going to talk about the lateral joint approach. And the idea is you start from above and you start seeing the C2, and when you start going downwards, start counting the spinous process and go sidewise. As soon as you go sidewise, keep your transducer in the corner, in the longitudinal plane, and you start seeing the sawtooth appearance, and you really know which level you are in. And once you know the level, you can inject the level accordingly. And this is what they've done. Panoramic view is there. And I give you one little guide. You can scan with the linear transducer, but as soon as you want to do a procedure, a curved transducer is better because you can see longer length of needle. And although there are some needle tracking devices also there, make use of those machines. They are very, very helpful. And you can really go right there in the posteriorly, you can go into the intra-articular, but don't go beyond. As soon as your tip touches the posterior joint capsule, you don't have to go beyond, because then it's blind. You may go anteriorly and it can be disastrous. Now this is about the Facet Nerve block. You just seeing, by the way, you're seeing the joint line here, lateral joint line in here, and this is the crest and trough, and the crest is where the joint is there, trough is where the nerve is there. And this is when you're going from sidewise, you can really do the injection this way also. People have liking for this, and I always say, have an M line of your transducer, which is the middle line, put it right there, this image in the middle of the image, and you take a needle just by the side of the transducer, get in there. A very, very helpful tool for superficial injections, and you can get into the joint there and can give injection. This is about the intra-articular. Now we're going to talk about the facet nerve anatomy. There's a change in the philosophy now, and understand this philosophy, very, very important. This image was very important, I thought I must share with you. That the nerves, they don't come like obliquely, like we have been talking ages, go and oblique. They have been going more straightish, or more horizontal, in other words. And even if you put a probe in there. But my guide to all my students and everybody who's there, that your stim is your best guide if you're doing an RF. If you're doing just injection, joint injection, it's a different thing. Facet nerve injection is a different thing. But if you're doing an RF, put your stim on and your stim tells you everything. You don't have to really think much about it. Now how we do it? Mastoid, go backwards, slightly backwards about a centimeter or two, and start piling down. As soon as you go down, you first see the C2-3 joint space. And at the C2-3 joint space, there is a third occipital nerve, TON. I'll show you a few images, beautiful images after this. And this is the crest and trough. You start seeing the C3 median branch and then C3-4 joint. And this, you start going a little further downwards. You can really count your levels, And you can really come, and C6 is there. C6 joint cleft is there. If you want to see C7, you just have to go slightly interior at C6-7 level. And then you start seeing the TP of C7, which is a little up there, and uphill is the nerve, which is C7 nerve lies a little uphill there. So you can start counting from C2-3, or you can start counting from below. It's always customary to start counting from C2-3 and go there, and you can really reconfirm, find your 4, 5, 5, 6 and 6, 7 level, which is more often there, positive there. This is what I was talking about. Your C7 median branch is going upscale when you're going uphill for the TP, C7, this is where the C7 median branch lies. Go and do your RF there, stim, and then you're really fine. One important observation is there. You see few of these halos there, and they are not, all are not nerves, So put a Doppler on. Sometimes you find vessels there. So be very careful when you have a vessel. You are not supposed to inject inside the vessel your LA or anything there for that matter. It's a waste, and it is deleterious also. So careful on that account. And that is how we do it. We go from anterior to posterior for C7 facial block, anterior to posterior, because you are avoiding going from posterior to anterior, because then you have all the structures coming in. I'll give you a lead. Go and sit on the bone. Have a touch on the bone first. Once you touch the bone, you put your drug in there and you should see your LA. You don't have to put much. 1 or 2 ml is more than enough. You don't have to put much of LA, because then it's going to go to the root. Some people say you even 0.3 ml LA is more than enough for this Facet Nerve diagnostic block, or you can do a therapeutic block if you want. And going from posterior to anterior is dangerous, I mentioned you, because you have anterior vertebral artery and other major structures, or root for that matter. That is not advisable. I just gave you a word of caution. That is how I try to see this. Now this is the Korean method. They see in a coronal longitudinal axis, and they go in plane, and they put a needle in there, and they sit in the groove in there and do your injection. In this way you can do multiple places. For this joint you have to do a block here, block up there, and like for 2 joints you do a block here, and block there. So they do multiple blocks with a single needle, entry needle, and they can do this. This is a Korean method. Yes, it's very much doable, and with practice you can do more and more of this. Now I'm going to talk about the RF now quickly, and this is the RF. We just try to find the level where you want to do an RF. Put in the middle of the probe, right there I mentioned you, M line I told you. Take this, the M line, this is the middle of the line, and then you take your, find the depth, you have about centimeter depth, go a centimeter back, downwards, and then you start going inside. Now your needle will be shining up here for that matter in the cross section, but this is not, once we enter the needle, you immediately come in the parallel to the needle. Now you do a short axis view. Now you have this long axis of the needle for that matter. Then you start seeing the thing that your needle is walking in like this. You'll see few images. By the way, this is a facial pillar, this is the posterior tubercle, this is the anterior tubercle, and you have the nerve lying in there. And your posterior tubercle or posterior, this is very, very safeguarding this. Until you over jealously push a needle in there, it won't happen. And this is where you want to sit in there. This is a posterior tubercle. You really have to sit in here. Do your RF. You can really see your nerve is lying there. You put in LA and you do your RF. You can do very well do your RF. This is very, very helpful technique. All those things. And this is the 3D reconstruction. You have the nerve, posterior tubercle, anterior tubercle, facial pillar, laminas, and the spinous process. Yes, fluoroscopic validation. Yes, if you want. Yes, go ahead, do it. Till now the practice is always do a fluoroscopic validation for the RF. For LA, facet nerve, and LA intraarticular, you can do it. But when you do RF, you do a fluoroscopic validation. This is still the practice. Yes, one can choose to jump to full fluor ultrasound guidance if you want later on, once expertise. This is, some people want to do cryoanesthesia. It's a very, very good technique. If you don't want to do an RF, you can do a cryoanesthesia. Same thing, needle, and it's a different energy source. Now I'm going to talk about a cervico-trigeminal complex. We do have this third occipital and greater occipital nerves, and they come and give a problem. So I'll just quickly go. And this is what about the C2 is there. You must see the Doppler on. You first see the vertebral artery in there, and then you start seeing the C2 3 joints in there, and this is where the third occipital nerve would be lying, and you just start seeing in there like this. This third occipital nerve, and this is the median branch, and this is where you have to block for third occipital nerve. I'll show you a few images. This is where the third occipital nerve, the C2 3 joint. You don't miss on these things. And then you have the facial nerve in there. If you want to do facial nerve, you can do in there. And I'll tell you where we do with the RF and the block. Here we do in the ultrasound guidance, we do in a longitudinal axis like this, in a lateral patient in the lateral position, and you go from above and go there. Don't go from below up, because then you might just get in the vertebral artery or more ominous structures there. So you go from above down and just go and touch a bone. Bone is your friend here now. You touch a bone and do your block. But if you have to do an RF, yes, classical method is there. You have a C2 3 joint, and you know the lines where you have to be sitting right from the groove to the SAP, and that is where your nerve is there. And you put your probes parallel to this, and you can do with one needle. But I would like to combine and supplement, if you have to do combo procedure also, I would like to put ultrasound probe and check. I really see the nerve there, so I don't have to put 3 needles. Why we used to do 3 needles? We never knew where the nerve is there, and nerve is very large in size, so we used to do 3 RFs. This is about the occipital nerve, GON. So this beautiful image is there. You have the C2 bifid spinous process, and you have the GON nerve with there. Semispinal capitis, splenius capitis muscles are there. The IOCM is muscle is there. And this is where you have the, you really see it so beautifully if you put a probe in right thing. The probe, one end of it should be in the C2 spinous process, and the other end should be at the C1 arch. And this is how the muscle is obliquely placed, and you just see the cross section of the, this is the cross section of the nerve, and you see it beautifully. You don't miss on this nerve. If you start practicing, it's a beautiful way. I will never do it blind now. Sometimes the nerve can be bifid or trifid like this, and you really have to see, but always do a Doppler's. It may be vessel sometime, and then how you do it. I go from above below. I don't come from below above, because then you might, if you surpass, you might get into the foramen magnum. So we have to be careful. Going above below is a little safer, and you just go, and always measure your depth. This is your depth. Your needle should not go beyond this, and you should be seeing your tip of your needle. This is the outer plane approach. But yes, for some reason, if I have to do a hydrodissection, I have a beautiful image. I'll show you, and this is how it will show. Hello around the nerve. This is how it will show. And once you have to do a hydrodissection, you just do a perpendicular image. Just turn your probe 90 degree. Instead of now going like this, it is going this way. Just see this. This is medial, this is lateral now. You see the beautifully the nerve, GON nerve, and you can do hydrodissection. You go from the side lateral, or you can come from the medially. You can do hydrodissection, and this is coming from medially to lateral. So when you come medial lateral, you can do hydrodissection here. Lateral medial, hydrodissection here. When you go lateral medial, more careful not to go into the canal. And medial to lateral, more careful not to get into the vertebral artery. So this is what it is. But for hydrodissection, this is the best way. I would still advocate many people, if you want to do a neuromodulation technique, they can really see what plane they have to be in. They can really see the nerves also. And this is very, very helpful tool for a positive results. Many people failed these procedures because they were not in the right plane, and they have to use extra energy, and then there is to be muscle pain and muscle twitches there, which is not good. So people are failed for that reason. Many times they explanted the leads also. This is about the AAAO, just few leads, few points in here. And this is where you have to do a block for C0, C1, and this we do a block for C1, C2. Because the anatomy of the vertebral artery. Remember, but the vertebral artery is not your friend. It has very tortuous path and very anomalous paths at times. So your Doppler is a very, very helpful tool for the matter. Look at this beautiful image. Such a training, such a learning image in there. You have this C1, C2 joint in there, and your C2 now lies, just DRG just lies behind this. Just imagine this is it. And such a beautiful image. But if you have to do a block here, you do a block here because vertebral artery is going here. But if you have to do a C0, C1 block, you block in here, this C0, C1 joint. You don't block more medially because the vertebral artery is there. I told you it may be tortuous, so always good to go here. And it's always good to go at the center of the joint in here, instead of medially is the cord and laterally is the vertebral artery, and that is what you really try to see. This is where you're trying to be in place. There is the DRG. If you want to just do a C2 block, you can come and do it at the DRG level. And these are anatomies you should be very careful. It's not unusual. I do see C0, C1, C1, C2 arthritis. Occipital headaches, very, very helpful, very useful tool. And you go from the side, put your needle in there, put in a dye, and then you just do your block in here. But have to practice safe. These are high-end blocks. I want people to be expertise. Yes, it can be started doing with ultrasound guidance. I would only say the faculty in the team can manage to, because others will really have to learn it well. Only then they can start thinking of doing this ultrasound guidance. Blood fluoroscopic validation is required if you really want to do it. This is Neeraj's films, by the way. Professor Neeraj, he is the master, he can do it. Another important thing is C2 nerve block. Helpful for cervicogenic headaches. Very, very helpful. And you can do a C2 nerve block if you want to. And this is the picture for that reason. Last few slides about the trigeminal now, because the things are changing. Now, when you have the, this is called Cervico-Trigeminal complex. When you have trigeminal pain, people have a neck pain. When you have a neck pain, people have a frontal headache. So this all is known. This circuitry is already discovered, and it's actual neural circuitry. It's not just words. We stimulate here, there's a pain in their meninges, and we even stimulate right in front, and there is a pain in the lower neck, and this is there. And this is the few pictures, which is, I think this is a changing thing. Now this is about the we have the herpetic neuralgias and pain coming. We can do peripheral trigeminal blocks. in one line. This all is the line. You do the supratrochlear, supraorbital, you do infraorbital, you do mental nerve blocks, and you just see the things in there. Go from below up, don't come from above below, because the eye is there, and this is what you see. Sometimes you see the groove and the nerve both, and you can just go and sit on this thing. This is the infraorbital. You really see the infraorbital groove. You can really get into there, and you can get into sphenopalatine fissure and do your block there, like we do through Gerardo Palatine foramina. And this is about the mental nerve. Helpful tool, is satisfying. If you really see, you see the nerve, and you really see vessels also. Sometimes it's helpful. Another important thing is, people have started already doing infrazygomatic trigeminal blocks. You can really see beautiful the maxillary vessels there, and you go just deeper to that, and you deposit your drug with this for the sphenopalatine fissure blocks, for sphenopalatine ganglion or the maxillary nerve, which is helpful. So the idea is, then you can do these blocks ultrasound way also initially, but you do a fluoro ultrasound hybridization initially, and later on you can start doing it ultrasound way. And but yes, advised is you should start practicing from the other structures, other body structures first, and once you expertise yourself, then you can really jump on to the cervical. But I really find it very, very helpful in these scenarios, and I advocate my friends to learn it well, do it well, start from expertise, trigger points, and come to the neck, and you'll find it is very, very useful tool for that matter. Yes, I have been saying, do a combo initially, and then later on you can really jump onto the other things. Any questions will be more than welcome. I know I had to talk two things together, the neck and the head, that's why it took a little longer. So thanks my friends, thanks Dr. Krishna, thanks to the society, and thanks to other my faculty friends for bearing with me. Thank you so much, friends. Thank you so much.
Thank you, Dr.
Thank you,
Jain.
sir. Thank you, Dr. Jain. If there are any question, the participants can ask right now on head and neck block.
Anything you want, we can talk.
Or if anyone have the question, we can talk later on
Anytime,
also.
I'm on through and through the whole conference.
Thank you.
Anybody can come
Yeah.
with any question sooner or later. We can talk it out.
Yeah.
We can talk
Thank
it
you.
out.
I just want to ask, someone asked in occipital hydrodissection, how much volume you gave?
No, you're really seeing the volume. When you're injecting, you're seeing the nerve inflating. There's the nerve is all the drug is going all around the nerve, and you can really look, because many times it's an entrapment neuropathy, or it's a very nasty neuropathy. People have pain for ages together. Like, and even for headache, you can do this block. It is such a helpful block for even for headaches. You should practice. You get many patients of headache coming to you. Put your probe there, put your needle there, and do the hydrodissection, and it really gives a very, very good relief to these patients. So we have to understand, like all tunnel syndromes, this is another kind of entrapment neuropathy. You can really do a hydrodissection, and at the end of it, put your LA with the steroid, and there is a job done. Where there may be some situation where you might do an RF, although to be avoided. I have done RF in few patients, but yes, hydrodissection normally is more than enough. But you really have a satisfaction of seeing the nerve opening up through and through when you go in length of the nerve, That's the whole idea.
But what about the hairs, scalp hairs? What you do?
No, you have to really clean it well. Either you shave it or you have to clean it well. Obviously, you can't take chances, obviously. That is doable. This should not be an issue. When you do C0, C1, C1, C2 block, you don't shave all patients for that matter, You just do it, clean it
But
well,
for
nice well.
occipital, you have to shave.
Yeah, yes, for occipital stimulation, you have to. Obviously,
Yeah.
you have to.
Thank you.
Yeah, my pleasure. My
Okay.
pleasure, friends.
Thank you,
Everyone
thank you.
is praising. It's a fantastic lecture.
Thank you. Thank you,
So
friends.